All right, let's get right into it. Welcome to this high-yield explainer. Today, we're doing a rapid-fire review of Campylobacter to help you absolutely crush your medical board exams. Look, if you're prepping for your tests right now, you already know enteric pathogens are heavily tested, and honestly, this specific bug is an absolute favorite for question writers. So, grab a coffee and get ready to take some mental notes. We're going to kick things off with a classic vignette question just to test your reflexes. Picture this. A patient presents to the ED. They've got a fever, severe abdominal pain that looks exactly like appendicitis. And then, maybe a few weeks later, they start developing ascending muscle weakness. What pathogen causes that exact constellation of symptoms?
Yep, if you guessed Campylobacter, you are perfectly primed for today's hit list. This organism is notorious for its deceptive clinical presentations and its really severe post-infectious complications.
Here is our game plan to conquer this bug: microbiology and epidemiology, clinical features, C. fetus systemic disease, post-infectious sequelae, and we'll wrap up with treatment and exam warnings.
Okay, jumping right into Section 1, microbiology and epidemiology. Let's lock down those essential buzzwords.
You need to memorize these PYQ facts immediately. Campylobacter is a microaerophilic, curved, gram-negative rod. And a great way to remember its unique features is to think of a campfire. It has curved rods, shaped kind of like a mustache or a seagull, and it absolutely loves the heat. It grows at 42 degrees Celsius, making it thermophilic. To isolate it from a stool sample, which, is full of other bacteria, you have to use selective Skirrose medium, incubated with antibiotics in a CO2 environment at that exact 42-degree temperature.
Now, if you ever see the phrase darting motility in a question stem, your brain needs to instantly lock onto Campylobacter. This rapid zigzag movement is a defining feature when you're looking at it under phase contrast or dark field microscopy. Seriously, don't let them distract you with other modal bugs. Darting is your golden keyword here. Before we get into the symptoms, I want you to actively recall the transmission vehicle. Where is our hypothetical patient actually catching this infection from?
It's undercooked poultry, for sure. Anywhere from 30 to 70% of cases come from contaminated chicken. But keep your eyes peeled for other vignette clues like unpasteurized milk, untreated water, and, this is a really high-yield discriminator, recent contact with pets, especially puppies. It's actually the leading cause of traveler's diarrhea, with attack rates peaking in the summer and early autumn, mostly hitting young children and young adults.
Let's move on to Section 2, Clinical Features and Mimics. This is exactly where the exam is going to try and trick you.
So here's how the timeline usually plays out. It starts with an incubation period of about 1 to 7 days. This is followed by a very distinct prodrome lasting 12 to 48 hours, characterized by fever, headache, and myalgias. Do not ignore that prodrome. It's a key distinguishing feature. That leads directly into the intestinal phase, bringing on a self-limiting but really nasty diarrhea. It starts out watery but becomes bloody in about 10% of adults seeking care, along with some pretty severe abdominal cramping.
All right, clinical pearl right here. Campylobacter is a master of disguise. It can perfectly mimic appendicitis with severe right lower quadrant pain. We call that pseudoappendicitis. If the fever is the only initial symptom, it can look exactly like typhoid fever. And crucially, on biopsy, a Campylobacter infection can mimic inflammatory bowel disease. We're talking specifically ulcerative colitis or Crohn's disease. Keep that in your back pocket, it comes up a lot.
Section 3, C, Fetus Systemic Disease. Let's contrast our standard intestinal bug with its much more dangerous cousin.
You absolutely must know the head-to-head differences between these two. C. jejuni is primarily causing enteric diarrhea in the young and healthy. C. fetus, on the other hand, goes after the extremes of age and immunocompromised hosts. Think patients with AIDS, diabetes, or liver disease. It causes severe systemic infections. And it has this crazy high vascular tropism, meaning it literally loves blood vessels, leading to things like endocarditis, septic thrombophlebitis, and mycotic aneurysms. It is also a known cause of septic abortion.
So you might be wondering, why the massive difference in severity? Well, the specific reason C. fetus can seed into the blood and cause all these metastatic infections is this highly testable anti-phagocytic feature called the S layer. It's basically a proteinaceous, capsule-like armor that makes C. fetus resistant to serum complement and phagocytosis. C. jejuni doesn't have this armor, which is exactly why it stays confined to the gut.
Section 4, Post-infectious sequelae. The acute infection might resolve in a few days, but the danger is far from over.
Look at this massive number. C. jejuni is estimated to trigger 20 to 40% of all Guillain-Barré syndrome cases worldwide. This is an incredibly high-yield association. Roughly 1 in 1,000 to 2,000 cases of Campylobacter will develop GBS, and if we're talking about certain serotypes like O19, that risk jumps all the way to 1 in 100.
The most crucial takeaway here is the actual mechanism for this peripheral neuropathy. It all comes down to molecular mimicry. The sialylated lipooligosaccharides, or LPS, on the surface of C. jejuni look almost perfectly identical to the sialylated gangliosides on human peripheral nerve axons. So your immune system makes antibodies to fight off the bacteria, but then those exact same antibodies get confused, cross-react, and attack the patient's own nerves. Oh, and definitely note that the Miller-Fisher variant of GBS, the one with cranial polyneuropathy and anti-GQ1B antibodies, frequently follows a Campylobacter infection too. Now, please don't fall for this classic exam trap. Up to 2.5% of patients develop reactive arthritis weeks later, typically in their knees. But unlike other enteric bugs that cause Reiter's syndrome, Campylobacter reactive arthritis surprisingly lacks an HLA-B27 association. Zero association. Also, just as a quick aside, remember the rare link to IPSID, a small intestinal multitoma that remarkably improves with just simple antibiotic therapy.
All right, we made it to Section 5, Treatment and Exam Warnings. Let's lock in these final points to secure that top score.
First off, fluid and electrolyte replacement is the core therapy for most patients. Like we said, it's usually self-limiting. But if antibiotics are actually indicated, let's say for a really high fever, severe bloody diarrhea, symptoms that are dragging on past a week, or if you're dealing with an immunocompromised patient, azithromycin is your unquestionable drug of choice. Standard dose is 500 milligrams once daily for 3 days. Macrolides are preferred empirically simply because their resistance rate is incredibly low.
Which brings us to fluoroquinolones. You might be asking, why not just use Cipro or Levo? Well, because resistance is astronomically high. It's sitting at around 27% in US isolates, and it's even higher internationally. If you have a patient with travel-associated Campylobacter, you essentially have to assume it's fluoroquinolone resistant.
I want to aggressively highlight these absolute rule-outs for both the boards and the wards. Never ever give antimotility drugs like loperamide. There's a severe risk of triggering toxic megacolon and even death. On top of that, C. jejuni is naturally resistant to trimethoprim sulfamethoxazole, as well as most beta-lactams, including penicillins and most cephalosporins. If you happen to be dealing with a severe systemic C. fetus infection, you'll need to escalate way up to carbapenems like imipenem or meropenem for up to 4 weeks.
As we wrap up this explainer, I want to leave you with a real-world clinical thought to chew on. Always ask yourself in the clinic, before slapping a lifelong, heavy, inflammatory bowel disease diagnosis on a young adult who just recently traveled or maybe got a cute new puppy, did we truly rule out Campylobacter? Remember, it mimics UC and Crohn's perfectly on both the clinical presentation and the biopsy. Keep your differentials broad, trust your microbiology, and you are going to absolutely crush your boards. Thanks for learning with me today.